Hello everyone, this is Chadi Alraies from SIF 2024, and this is the 20th anniversary coming to you with Dr. Chintan Patel to talk about a very innovative, out-of-the-box technique for treating coronary aneurysm. Dr. Patel, thanks for being with us.
Oh, thank you for having me. I really appreciate it.
So one of the highlights of the meeting is showing challenging and also innovative way to check for coronary and structural heart disease. Mm-hmm. So tell us about your case.
Sure. So I had a pleasure of meeting a guy, 58-year-old guy, known history of some coronary disease, but he didn't quite know what was going on. He thought he had a stent, very questionable history, bad anginal discomfort that eventually, with the workup, led to a cardiac catheterization. And lo and behold, he had a left dominant system with a large 8-centimeter coronary aneurysm. And so with that, he was having turbulent flow and he had some LAD disease. Mm-hmm. So our first modality of treating this was to send him for bypass, for which he got a Lima to LAD and a vein graft to an obtuse marginal. However, it was proximal to the actual aneurysm.
Oh, wow.
So the initial thought was to try to bypass the PDA, which would be distal to it, so to eliminate the aneurysm's contribution to that flow. But because it was proximal, and for whatever technical reason they couldn't get, it ended up altering the hemodynamics within that coronary system, because now you're getting native flow and flow from the bypass.
Creating a perfect storm.
Exactly. So you're starting to create turbulence within the aneurysm segment. He did okay after bypass with medical therapy, aspirin and Plavix. He was okay for about 3 months, but then he had a STEMI. And with that STEMI, we saw that his circumflex was 100% occlusion. Because of the aneurysm and the structure that it was, there's no good stent, traditional stent option. He already had bypass, so the option at that point was just to balloon it, put him on a 2B3A, and put him on a DOAC, like Xarelto. However, 2 weeks later, he had another STEMI, despite being on aspirin, Plavix, and Xarelto at this point. In the same territory. Additionally, his Lima had actually gone down. And so,
I think most likely from the competitive flow coming.
Exactly. There's the flow dynamics. You know, we measure a lot of things when it comes to stenosis and significance when it comes to IFR and FFR, but I think in large coronary systems, we still don't have a great understanding of the turbulence that can contribute to this. Right. We fixed his LAD, and it was in between the two STEMIs that we fixed the LAD because the Lima went down. And
which is distal to the aneurysm?
The LAD was isolated. That was an isolated issue because the Lima had gone down. But the aneurysm, we still didn't know a good solution for this. Right. And this is where the innovation part comes in. I had the pleasure of working with Dr. Alexander Kuhn down in Tucson in my original practice, who's an interventional neurosurgeon. And his main thing is to fix intracerebral aneurysms. And he uses a lot of the same techniques we use, but in the neurosurgical world and the endovascular world, it's a different toolbox altogether. And so one of the things that he used is a flow diverting stent. Now our stents are traditionally used to provide radial strength to try to support the artery and then also try to diminish any additional plaque buildup. In their world, they want laminar flow to bypass the aneurysm and exclude it as much as possible. We use covered stents, but they're not on label for use for this purpose. And of course, with a covered stent, you lose any side branches. Here, they preserve side branch flow. They can't afford to in the brain to occlude anything. And so with his guidance, we were able to use it via right radial, 7 French system. So same traditional kind of thing. There's nothing special about that. And create a scaffold of stent that goes through the aneurysm. So there was a distal anchor point and a proximal anchor point where we were able to use 4.0 stents. And then put a 4.0/48 stent through the aneurysm, but now it's floating in there. And the whole purpose of that was to provide an anchor point for us to put a self-expanding nitinol stent made by Stryker called the Surpass Evolve. 68 braided wires that are intermeshed, and the idea is that flow will go down with a little bit excluding into the porous portion of it. Now, if you put a stent down in an area that's got a side branch, laminar flow and flow dynamics dictate that it'll go and it'll preserve that area because it's porous. But in the aneurysm segment, where flow is more stagnant, it'll eventually clot off because there's nowhere for it to go anywhere. And so we did this in July of last year, brought him back to confirm that everything was going well for him back about 7 weeks later. 7 weeks later, 90% of the aneurysm had been excluded. And so now we get a thin sliver, and looking at neurosurgical data, they say up to 2 years before you get complete exclusion. we needed an excuse to recath him again, and he had a ventral hernia surgery with some minor chest discomfort. So we said, with his permission and fully explaining the risk and benefits, he said, take me back and let's take a look. And now we had almost 95% with just a little bit of an area that was kind of it almost looks like a perforation if you look at it, which is kind of scary. But it's really just the aneurysm filling, and you can see that it's clotting off slowly and slowly.
Perfect.
With perfect laminar flow, providing PDA flow and large obtuse marginal flow, and completed cardiac rehab, no additional chest pain, and now he's on aspirin monotherapy.
And no more STEMIs.
No more STEMIs. I think 1 month of STEMIs is enough to really hurt somebody.
Yeah. And in terms of sizing, is there different sizes of
There is,
stent?
yeah. So we can go up to 6 millimeters in diameter. And remember, these are self-expanding. And so 6 millimeters in diameter and up to 52 millimeters in length. So you can get, and you can overlap them as well. Our interventional neurosurgeon was actually the one that had suggested creating the scaffold within the aneurysmal part, because unlike in the neurological world, we have a lot more movement. The heart's beating. And this stent doesn't provide radial support. So before you get a kink in the stent or anything, the scaffold allows it to be able to take up that area. And they've used this technique in the brain as well to create a scaffold in an area that might have some atherosclerosis.
What is the off-label use paperwork you have to go through?
So
Just the patient consent?
Patient consent. Stryker we reached out to Stryker, and they had told us that they actually have off-label use anywhere in the body.
Oh, okay.
And so it has been used in the past for mesenteric aneurysms, but this is the first reported case in the heart.
Because as you said, the heart is moving constantly.
Yeah,
It's different
actually, during our time when putting it up, our interventional neurosurgeon got very dizzy. Because here we had the circumflex, AV groove circumflex, and it's moving. And he goes, how do you get this thing to stop moving? And I told him, if it stops moving, we have a problem. We have a big problem.
problem. Well, that's great. So monotherapy now after 1 year, he's doing well.
And he's doing completely chest pain free. He's actually a lot more active. He said he's never felt this good, because before the initial catheterization, he had anginal symptoms.
Yeah.
Never really got better after surgery. Now completely chest pain.
Awesome. And then we talked about it offline in terms of CTA, in terms of compared to angio, but definitely this will give you more comfort. But maybe down the line.
No. So yeah,
CTA
we're able in between. Through sponsorship from Simon Med, we were able to actually get a free CTA for him. To be perfectly honest, between his hospital stays and his bypass, he was in financial straits because of that. So with this free CTA, we actually got a chance, and we did see good laminar flow through them.
Nice, yeah.
And we see the aneurysm size actually shrinking.
Nice.
It was still present with some there, and it takes, like I said, up to 2 years to get complete resolution. And so I think going forward for him
is the best thing.
Yeah, I mean, exactly. Like symptoms-wise, and the other nice thing about this stent, because it is porous, you can use a .009 wire to go through one of the pores and dilate it further. So if you had to do a side branch stent technique, you still could.
You can, okay. Nice.
Yeah.
Well, thank you so much, Dr.
Oh, absolutely. No, thank you.
Talk again, and good presentation in an innovative way. Watch these videos and others on SIF YouTube channel. This is Chadi Alraies from SIF 2024. Thank you so much.
Thank you.